great to follow. It's great to follow the respiratory physician. I had to put a tie on for your event, and I'm almost suffocating and choking, and I might start to have narcolepsy and probably collapse in hypoxia. But that's me. And we go through the next half an hour with a brief overview, and then Alice has got a quiz, and she's got a prize for you as well for the top player. Right, okay. So, just 3 slides from me, just to show you how little I know, and that's more than enough. So, balance is fairly complex and sort of worrying to people when you have a patient who walks in and says, I'm dizzy all the time, every day, most days of the year, and that's the end of their history. 3 things you need to know, and that's all again, as I said, that's all I remember, is there are inputs from 3 different basic senses: proprioception, vision, and joint and the inner ear. Any takers for one simple question, which one do you think is the most important input of the 3 on the left? Any takers, no prizes for this, so you can try. Vision, absolutely. Vision is the most important one. But the most disruptive is when the inner ear starts to give you grief. So all that is integrated by the supercomputer called the brain, and then it kind of makes an output towards the visual clues to follow whatever's happening around you. And if the visual clues are disturbed, then you essentially can't make sense of the world, and you develop something like what we know as nystagmus. So any of these input areas which are disrupted by surfaces, surroundings, or inertia will give rise to a sensation of disequilibrium. 2 more slides. If you forget everything else, just remember this. And this is all I remember in the balance clinic, to be honest, and I'm being absolutely honest. So, vestibular causes of balance disorders are few and far between. Majority of the causes are non-vestibular and medical in nature. But they cause a lot more disequilibrium, whereas vestibular causes tend to give you more rotatory sensation, will have vegetative symptoms, nausea, vomiting, etc., and an odd sense of feeling. So those are your main conditions which you come across in the patient's experience. This is the only other slide. When I start taking a history, and when you do as well, if you ask and try and get them to focus on 2 aspects of their history. Are you feeling a sensation of spinning? Are you in a washing machine or in a whirlpool? Or are you unsteady all the time? So those 2, if you break that down, immediately you're putting them into one box or the other. And that actually guides you very simply. If they say, yeah, I get a very peculiar spinning sensation, the world spins around, the wardrobe spins around, I feel as if I'm in a washing machine. Is it for seconds? Does it happen when you're getting in and out of bed, rolling over in bed predictably every time? It's BPPV. You don't even, the rest of the history can be the cat died and the niece got eloped with somebody and their house was repossessed. It doesn't really matter. But you still have to listen to that, but you already and when you do the Epley's maneuver, they can think you can walk on water. If it's minutes, they're nauseous, and it comes with certain triggers, it's potentially Meniere's disease. Roughly about 20 minutes to anything longer. If it's for hours and days, and they're walking out like a crab for a few days, crawling to the toilet, that is likely to be labyrinthitis. Again, days, with an odd set of symptoms, dietary triggers, photophobia, etc., vestibular migraine. Then there's a huge plethora of symptoms where you get autophony, bobbing oscillopsia, etc., which don't fit into anything else at all, and you're sure that they're not imagining it. It's very likely to be severe sensory retinal dehiscence. Whereas the other ones, where there's unsteadiness, it's chronic disequilibrium, falling, etc., which has not been helped with any medication, chances are these on the right-hand side, but the history will be quite sort of obvious for them. The reason why you want these 2 boxes are for your referral pathway as well. You can try medications, you can try maneuvers, and then of everything else we can do to still operate on many of these balance organs. Whereas here, therapy works. And don't get me wrong, we get it wrong, and oftentimes, and Alice would have seen it time and again, dizzy patient goes to physiotherapist, and the physiotherapist tearing their hair out, and they're just quickly wanting to move to MSK because they're fed up of these dizzy patients landing on them. Whereas these benefit very well from physiotherapy. That's me done, and then that, honestly, that's all you need to remember. Alice.
We can sit down, can't we, really? So I'm just going to go through a few little bits of some hopefully nice, easy things that will hopefully be a bit of revision, but also a bit of knowledge acquisition of things you can do in the community to help delineate between whether you're thinking more, is this related to someone's ear, does it need to go to ENT, or is this actually something more that we can manage pretty well in the community and sort of cut things off at source, rather than waiting for these patients to get more serious consequences of more chronic imbalance, where they become more unsteady, they become a little bit more unconfident, they fall over, and I think really trying to make you enthused about balance, because it's really interesting. As much as I know you'll hate it when you get a dizzy patient, do not fear it, it's okay. First thing I'd like you all to do, because I think everyone is very postprandial and a bit, subdued. Stand up for me, please. So this is just a global demonstration of how your balance can alter and change with age. Now I think the demographic in the room, I would say that there may be only a few people over 40 in here, but just in case, just a humanly, if you could all, I'm not videoing this for YouTube by the way, it is being recorded, but I'm not sure whether this will try well. Literally want you to stand still. I want you to put one leg up with your eyes open, whichever leg you want, it doesn't matter, and then close your eyes, and hopefully no one's going to fall over and actually do something majorly harmful. Yeah, okay, so again, there's obviously a couple of people in here that practice yoga, do some Pilates and things like that, well done, but most of you are a little bit unsteady there. So have a seat down. That's how much your balance will change as you age and mature. So whilst I know we're all sort of focusing heavily on the ear today, it is something that has lots and lots of facets. So don't automatically assume that all patients in front of you has got an ear problem. It can be part of something a bit wider, more like a multifactorial balance disorder. So just from a referral perspective, especially in cases, if you've got an 89-year-old lady who's in a wheelchair who is feeling a bit unbalanced and unsteady, I'm not sure what's expected of dizzy imbalance clinic, but there's not necessarily going to be very much we're going to offer this lady, and we'd probably be better managing her sort of more in the community and really with falls prevention and things like that. So yeah, just an overview of what we're going to talk about. We're going to do a bit about the dizzy patient and trying to avoid that heart state, because I know it happens to everybody. And then we're going to do some easy things you can do, look at what we can do in the community for sort of helping to sort of hone our clinical skills, I guess, from a perspective of examination. I've got a quiz. You have to going to persevere with me with that one, because I'm using Woo Flap, and it's notoriously failed me on many occasions, so you might just do it an old-fashioned way, put your hands up. So we'll try it and see what happens. And then there'll be some time for some questions at the end if you'd like, or if you're all gone to sleep, that's also fine. So really, the dizzy patient and how to avoid the heart state. The key with a lot of things in sort of balance is focus a lot on history, but there's also a lot of things you can do as part of your examination. So Bob's already gone through the kind of key things that you're using, but I can't emphasise the history really is 90% of the diagnosis with anything dizzy. We don't have a lot of time, we have 15 minutes to really delineate whether is this person having a stroke, or have they got something a little bit less intense from a kind of severity perspective of their ear, and that's really hard to do. So you'll do your basics of history taking, and then focus more on the examination. You can get a lot of information from looking in the ears, quick cranial nerves, a bit of cerebellar function. If you want to be more fancy, you can use some dynamic visual acuity. And I thought just for demonstration purposes, because we've got a resident expert, it might be quite useful just to see how easy and quick it can be to do quick cranial nerves and a bit of a cerebellar function assessment. So we've got a very willing volunteer here. This is
I've got
Nabil.
a glamorous assistant here. So you guys know Nabil, I'm sure. So quick cranial nerve?
Yeah, quick
Yeah,
cranial
so
nerves.
once you're doing a cranial,
No
so
pressure.
everybody knows that there are 12 cranial nerves, right? So, okay, so if you do, when you're testing for nystagmus, keep your head still, just focus on my finger. You're looking at nystagmus, plus you're looking at 3, 4, 6 cranial nerves straight away. When they're talking, if there's no nasal intonation or they're not struggling to speak, there's no problems with the 10th cranial nerve, most likely. Shrug your shoulders for me and turn your head from side to side. Most likely 11th is fine. Open your mouth wide. Let's have a look at the palate. Say ah. So the tongue's moving fine and the palate's moving fine. So most likely the 12th, and so it's as quick as that. And if you just open your jaw, you're right. So the 5th cranial nerve is most likely to be fine. That's a very crude examination, but you're done that quickly. So, and the patient's happy if you put a hand on them. You're healing them. And then you can just go past pointing quickly for a cerebral signs, and they love doing that as well.
Okay. So we're going to do a few other little examination tips as well. One of the other one we just mentioned with dynamic visual acuity. Do you have Snellen charts in your room that probably, be honest, put your hands up if you ever use those. Well done. But in terms, mine sits on the back of the door, and I'll be really honest. This is a bit of a nugget for myself, to be honest, that we can do and probably should do more. But it's a really nice, easy one to do. Again, so you need the Snellen chart, and then you just ask the patient very slowly to keep sort of fixating on the Snellen chart and see what letters they can read. And really, if they're dropping more than 2 lines, there's potentially a bit of a problem there. It's very easy to do. These are some other ones that we like to do. So we'll do the tag and gate one. I always really enjoy because there's patients feel like there's a sense of jeopardy if they do deviate from the flat line that's on the floor with nothing either side. So often we'll say to them that don't be afraid, if you do go off the line, there's not an abyss that's going to open up and you're going to disappear down.
I just tell them, imagine you're a supermodel and do a catwalk.
Okay, that's a good way. So that's another thing that's really easy to do. Often you'll find your lino on your floor has got a nice straight line that you can again just, and do you know what the hand, so let's just demonstrate it anyway. Lovely.
And you want them to look forward.
Straight ahead,
and if you want to be really cruel, ask them to close their eyes, but you have to be close to them.
Yeah. So the Dick's Hall pipe manoeuvre is really interesting. That's something that we all should do. I know the room setup in quite a lot of GP practice isn't necessarily always in favour of that, but it's really easy and it really helps delineate. And I'm astounded always at how the cases referrals come through with, can you do an EPLI or can you do a Dick's Hall pipe? We can all do them. It's really straightforward and it's not hard. The patient doesn't mind it, and if it's just making sure you've established sometimes whether they've driven to a session or they've got someone that might be able to pick their car up, and if you forewarn them and they're not in a position to have it done right now, you can just bring them back a bit later and do it again in the treatment room, for example, where you've got space to move around the bed. You've also maybe got an opportunity to ask a member of your nursing team or one of the healthcare assistants or even reception just to come and assist you as a chaperone, because if they do start vomiting really violently in your room, you want another pair of hands for a sick bowl more than anything. And always, always, always give your patient a sick bowl anyway, just in case. You'll only ever not give them a sick bowl once, and otherwise you've ruined your shoes.
I think you need to look outside the window when they've left in case they're clutching onto the lamppost and can't go home.
The Unterberger's and the Romberg's test, the head impulse test is really easy again. Do you want to demo very quickly?
It's more or less like a head shake. So
I think the other thing to mention just quickly is to make sure that they haven't got a neck problem, because you don't want
check if
to
the
rip their
neck
head.
is free. For elderly, it's not that easy. So what you want to do is, if they can spontaneously move their head, but the head thrust is much easier. So tell them, I'm going to move your head suddenly in a jerky fashion. So as you do that, and don't resist. He's too loose because a natural patient won't be like that. So as you do that, you look for a jerky lag in the eye movement, and that also shows a peripheral vestibular deficit, but it doesn't give you directionality. The Unterberger's the Romberg's is simple, you know that, and sometimes patients might exaggerate the Romberg's response because if they're wanting more empathy because they've gone to so many doctors who've not shown them empathy. If you ask them to do a sort of more a distraction technique. Just ask them to move their hands or count 10 backwards. They'll do the rhombus much better. Unterbergers, so yeah, close your eyes, and if you march on the spot as if you're marching back to Munich, and that's it, lovely, thank you. So it's not so short, but you will want about 50 steps of those if there's an asymmetry between the balance organs, because you're totally now reliant. Remember those three inputs: proprioception, vision, proprioception, and inner ear. You've taken vision out, you've taken proprioception out because you're continuously moving, but if there's an asymmetry between the two sides, the patient will rotate. Doesn't give you any more information than that. And tell them it's not a party trick, don't try it on friends even when they're drunk.
And I always say that I'm not videoing it because I think people feel a bit silly. Yeah. We are videoing it today actually, but normally you're not. I put a slide in, well, we've got some slides about nystagmus, and I don't really want to get overly bogged down in that. It's kind of self-explanatory, and these slides are available after we've finished. That's just revision really from back in the eons of medical school a while ago, and similarly with the differentiation of the different types, central versus peripheral, it's very self-explanatory. Unfortunately, I can't demonstrate it. I don't have it as a nystagmus myself at the moment. So there are videos and all sorts of other things you can look online if you want to get more in-depth knowledge on nystagmus. But I think that sometimes the point is, do you have it or do you not? And then really this slide I've just popped in really from perspective of changing your management really more than anything. I think a lot of the referrals we get through cases are from patients who are having persisting dizziness, persisting imbalance. They've had things tried in the community, and actually sometimes the time frames of when their symptoms have started versus when they're still experiencing symptoms are actually quite short. So I think in GP, one of the things that we have is the gift of, well, not necessarily personal time, but we have the gift of time with patients. So it does a knee-jerk reaction to sort of hearing imbalance, but it doesn't necessarily have to happen at time of contact. You've got time to perhaps see how your intervention makes a difference and encourage that patient that, you know, this isn't going to get better overnight. The medicines aren't necessarily going to be effective. Some of the exercises we're going to be asking you to do are going to bring on your symptoms. I think if we can drill that in, especially with some of the sort of more visual vertigo patients, some of the more benign paroxysmal positional vertigo patients, if you explain at the very beginning, firstly, a little bit about the pathology and why it happens, and then secondly, what you're expecting the patient to experience with the exercises you're given, they have a little bit of a more realistic idea of what their process is going to be. And I think really reinforcing that what we're trying to do is improve their balance. We're not, if they couldn't walk in a straight line before this happened, they may not be able to walk in a straight line after this happened, but we can certainly help with their symptoms to make it less impactful from their way of life. And the key really is that we want to avoid them from falling over. That's the main thing. I
think the main problem with balance patients is because the vision stimulates them, they just go around like a toy soldier or a wooden doll. So they avoid neck movement, and the classic history, they'll say, I get pain here, neck hurts, etc. That's all acquired sort of behavior because they are becoming very protective. So the exercise, as generic, even Cawthorne Cooksey, is to release those sort of stiffnesses. And as a result of their change in gait and the behavior that they develop, they start to lose their core sort of muscular strength. Simple one-leg stand next to a dining chair, or when they're brushing their teeth, doing squats, etc., will stop them from falling over. And I didn't put the slides on the cost of fragility fractures as a result of disequilibrium is in billions, really. So if you can just prevent that for them, you're already winning. And those on those slides, the balance retraining, exercise, and polypharmacy are the three things. If you focus on, you really get rid of many of your referrals.
I think the other thing to emphasise with balance is it's no different from anything else that anyone does in the gym. Most people will go to the gym, do fitness, and as we age, it reduces. So I think encouraging people to have an awareness of their balance. I think everyone's alarmed when they get to sort of like 60, 65. They feel like they're a bit unsteady suddenly. But if they've not been sort of training their balance from, really, you don't think of it much after you're about 5, do you? You see kids running and zooming around, they manage to avoid corners of tables like you wouldn't believe, but sort of when you're a bit more grown up, you walk into the table label of it. It's something that you really should be training like you do anything else. So I always will emphasise for my patients, especially in the community, that perhaps have got a bit of a lower residual fitness level. Things like Tai Chi, really easy. Loads of people can get it online now because it's essentially free. Also, it's good for their core stability, it's good for their muscle maintenance, it's good for their sort of balance, it's good for their blood pressure, it's good for their mental health. It's got so many benefits, and I know they look at me anyway because I stand up at work like I'm really weird and a bit of a hippie and all, that's fine, but it does make a genuine impact, and it really can help their balance moving forward. So if you've got anything like that available to you, we're the kind of gatekeepers in the community to that more holistic care. We should be encouraging that. Right, so enough talking, let's do a quiz. So this is where we've got it. So if you can get your phones up, we're going to try this. If it works, I'm really happy. If it doesn't, then don't worry about it. It's the last time I'm subscribing to it. So basically, you should scan the QR codes, and a question should come up. Is that happening? Somebody that scanned it? Yeah. So has it given you all of the information about the question? Like a case? Or is it just giving you a list of answers?
No vote in progress.
Oh my gosh, what's that mean? So, raise your head, there's no vote in progress. Right, okay. So we'll have to do something now. Right, okay. Okay, you've got it? Woo. So, I'm going to go to the case. 1 second, don't cheat, try not to look at the questions. Okay, so, oh, it's gone, that's because I'm off it. Right, oh my life. This is ridiculous. I'm not using the recap again. Okay, so let me just check I've got the case on here. Might not have gone in here. Right, okay, yeah, we have. Brilliant. So we've got a 50-year-old businessman who's got a sudden onset, very violent rotatory vertigo. Episodes lasting 6 hours. Symptoms started 18 months ago. Since then, he's had some shorter attacks. He gets a lot of nausea, vomiting, and he gets this auricular fullness. And he can also experience a bit of a same-sided hearing loss with a peak of tinnitus. This is a lovely gift if you ever get someone that presents like this. So if you want to submit your answers, it should come up on here. Oh, for goodness sake. Oh, I'm gutted. That doesn't seem to... You cannot vote anymore. Why not? I've not even started it. I was going to say, well, should we bid it? Okay, so anybody want to volunteer what this might be? Oh, yes, well done. So yeah, this is Meniere's disease, and we've kind of put a little bit of extra information on there, and it's a really tricky one. We were just discussing this before we started. The main impact of the diagnosis of something like Meniere's disease is on your functional capacity from a driving perspective, and how you manage it with regards to your medications and things. Again, a lot of the referrals we get through cases are query Meniere's disease. I think you can float the idea of it with the patient and give them advice and start treatment in the community as per things like CKS. But this, to have Meniere's disease, it's a very classic sort of set of symptoms. So I think float it, and I think introduce the concept of it to a patient. But again, be mindful that we're seeing these people at the front door, so they don't necessarily get seen in a hearing and balance clinic with the best will in the world, potentially for quite a long time. We're trying really hard to skim down those lists, but it can be 12 to 18 months. So if you've got somebody that's really dizzy for that length of time, their general mental health, lots of things will be affected by these episodes that they're experiencing. So introduce the idea of it, try some management options, but again, give them a realistic expectation and what's going to happen in clinic, which is basically a hearing test, a bit more in-depth balance assessment, possibly maybe needing a scan. If it's unilateral, we would scan anyway in the community. Anything that was flagged would change how you refer onwards anyway. And yeah, Meniere's, that's Meniere's. So case 2, we've got a 30-year-old IT analyst who's got some autophony with a migraine and headache, really tired. They get this kind of chronic sensation, they're just a bit off balance. They're getting a really horrible full sensation in their ear, and it's in sync with their pulse. And we mentioned this earlier with Tudio phenomena and bobbing oscillopsia, which I find really difficult to say. And basically they've got a bit of a low frequency hearing loss, and again, fullness in the affected ear. You would be forgiven for thinking this could be slightly more Meniere's, but I'm going to tell you it's not.
It's the one which doesn't fit with anything else.
So this is a bit of a funny one. I think it's sort of. I think this is. I think you'd get 1 million points if you diagnosed that in the community. So I think you'd do really. I'd be delighted if that were the case. It's one of those ones that I think sometimes also people are a bit over enthusiastic to potentially diagnose. They're the kind of classic ways in which patients present, but again, it can be confusing. With regards to imaging and things in the community, anybody want to suggest what you might want to do that might be slightly different to what we do for a unilateral tinnitus? Yeah.
But ChatGPT diagnoses it for them.
Yeah.
No, it's 3.5% population incidence. So you probably in your life, whole career, you might see one. We see 2 or 3 per year.
So it's a bit of a rare one, but it's one of those ones you just have if you're not quite fitting any of the usual standard things, and it's a bit atypical. Have it there because it's really worthy and important diagnosis. And like I say, you'll get a gold star.
It's harder because now, as I said, ChatGPT will bring these up, and so they'll come to you. So being aware of it is quite important, because otherwise, if you dismiss it, they'll still insist on the diagnosis. So if you know, then it's easier to dismiss when you know that the condition exists and they don't fit into that.
And this is just some pictures of what it looks like.
Essentially, the superior canal should have bone over it, superior semicircular canal, but the bone's thinned out for some reason. It's an anatomical defect, but they get symptomatic in middle sort of 30s to 40s, and the brain's movement is essentially replicated through the vestibular system, which is why when they go over a bump or something, they hear it. And it's called the third window phenomenon. So the sound comes in and then dissipates into this echo chamber, which we call the skull. And then they hear their own voice, hear weird sounds. They even hear their eyeballs move. And so the temptation is to treat them as a mental health issue. But because now they get the diagnosis readily, you would want to avoid that, because they get very angry eventually when the penny drops and they were treated as malingerers of imagining it.
So the next one is a 28-year-old female primary school teacher who has some recurrent rotational vertigo, less than 2 minutes, lasts 3 months, and it's worse when rolling to the left and when rolling in bed. They've been so extreme that when she first started them, she was really unwell, but that's now settled. There's no other symptoms at all, and you've got a nice room, and her Dix-Hall pipe's positive on the left. Yeah. So yeah, again, that's a nice one, easy, straightforward, I think. And these are some, I think from another slide, there's some from slide, they're kind of slightly more, I really like them because they're a bit more vintage textbook sort of pictures, but they're just showing the semicircular canals really, and the theory really. You know that obviously the inner ear is integral to the scaffold of your skull, so it basically, if you were to peel your skin off, you can't really see very much at all. You have to drill these structures out when you're doing anything near them.
I'll just borrow my assistant and demonstrate.
We're just going to drill his brain and do some surgery now.
The reason I want to show you is that you want to be at the head end of your couch, and then I won't drop him because he'll get a head injury. See, you want the head to be one side, but off the couch. If you stand or sit behind, it's much easier to handle the patient. Whereas a lot of people, including ENT clinicians, do it that way. Imagine the patient gets dizzy or terrified. You can't get rid of the patient. So I always make sure I'm far away. And if they throw,
that's it. Yeah, that's.
Do one side, sit them up, ask them to focus. Do another side, do that. And if they're symptomatic, they're violently dizzy, and the eye is doing a retrophic nystagmus going towards the dependent ear. The Achilles maneuver is as simple as getting them back down, head from this side, all the way to that side, roll over, come off the couch on that side. Thank you very much, sir.
I think the other thing to warn patients as well, if they have that, is the other thing I always say is you're not going anywhere. You are still on a bed. I have your head. It's okay. It will settle, because immediately has anyone ever had BPPV in here? It's awful, and it's like you've had too many sherries and you haven't, and it's terrible. The room is going like crazy, and you just feel like you're going to fall into an abyss. And I think if you tell patients that that's okay, talk them through, keep them calm, make sure they carry on breathing, and also say that it will settle, because you'll see, because the nystagmus will just slow and they become less symptomatic, and say it's stopping now, isn't it? You can always ask for reinforcement from them. But I think the forewarning is critical, because otherwise they just literally they will freak out, and it's not a nice experience for anybody. So sick bowl, if you take nothing more, and just warn them what you're going to do. And the reason I always say to my patients is, have you driven? Because often you can make them feel a bit worse and unsteady after you've done it. So if they've got someone that can take the car home, they're not going to crash on the way out of your surgery. That's a bonus.
There's a latent period of about 40 seconds. You really need to wait when the head is dependent, because if you think, well, nothing's happened, that's probably not right. So 40 seconds, and it'll pass in a minute max. So you have to reassure them, just stay there, it'll fine. You're not going anywhere, as you said.
I think it's you're not going anywhere. They think they're going to be like falling off, or something, their bed's going to disappear, the whole room's going to go. Because it does feel like that.
So just avoid this, because it is very awkward if the patient gets hold of you. It's very standing behind definitely is better.
I think that's also where our rooms in GP sometimes can really obstruct doing that. So I think if you don't be afraid to move your furniture around. I'm always moving my couch in and out. I think maybe it's because I get all the dizzy patients in my practice, which is great. But in terms of it, just move things around a bit to facilitate that. And if you haven't got space, do it in the treatment room. It's fine, and usually got a lino floor if they are sick. You can clean it up rather than the carpets. Okay, so you've got a 26-year-old hairdresser struggling at work with increasing episodes of nausea and vomiting. She drinks a lot of Monster Energy because she feels that's all that's keeping her going at the moment. She's got some slight visual disturbance, which is worsened by the night at work. The episodes become less frequent when she's away on holiday. That's the only pattern that she's noted to correlate with the symptoms, otherwise nothing much. She's got this general sense of being a bit off balance, and it's as if something's not quite right. And there's nothing to see at all on examination. It's normal ENT-wise. Yes. Yes, perfect. So ask them often to keep a diary of the triggers. So the Monster Energy in there was a bit of a giveaway. But you know, the things like that really make a massive difference. And I think when people are at work, again, in ENT it's one of the real specialties where your occupation can really change your management sometimes. So do always ask about, I know everyone at medical school, everyone's always asking about what you do for a living, but in ENT it really helps from a rhinology perspective, allergy, all sorts of other reasons. And then the other thing, just to make sure you're asking about again, is medications and recreational substances. And more recently actually Monjaro, which isn't necessarily, or Ozempic, whatever. Just make sure if you're not prescribing it, they're getting it elsewhere. You're just asking about that a little bit, because it's doing some all sorts of interesting, funny things. So there we are, and that's just a little bit about management about that. It's the same management for classic migraine. So 55-year-old postal worker presents with acute onset dizziness, disequilibrium. He's a bit malcoordinated, and he's not really able to stand up steady. He's been mistaken at work this morning for being under the influence of alcohol, and that's why he's been asked to come to the GP. He's got a bit of weakness in his legs, but there's nothing else in terms of assessment and examination. Yeah, so I think this is the one that we're all afraid of missing, actually, because you know, with dizziness, it's always interesting with it, everyone always goes directly to ear, when actually there's a lot of other things, sort of from a cardiovascular perspective and a neurological perspective, that are much more require much more immediate intervention. It's not negating that your ear can cause mayhem or your eyes can cause mayhem, but at the same time, you know, the main things you're wanting to rule out is something more central, and this is a kind of classic thing that you don't want to miss. So your assessment will be slightly different, making sure you're focusing on his blood pressure, his pulse, and things like that, which will sometimes be elevated. I mean, I had a patient that presented almost with classic BPPV symptoms, but the only thing that was off was her blood pressure, and it wasn't actually sky high, it was just kind of a bit out, and she'd had a stroke. So it's you have to just be mindful that stroke is one of the worst case scenarios. If you're concerned about that, then you implement your management for that. I think nobody really minds if you've got that, you haven't got that quite right. versus other problems.
The trouble is, you really need to rely on the HINT acronym as well, because sometimes these patients may not have a full-blown stroke or anything at all, but any acute vestibular, audiovestibular symptom, hearing loss, dizziness, in association with any neurology, ataxia is here, you can get tingling, numbness, slight facial droop, which just recovers over a few hours, very likely to be followed by a posterior circulation CVA within the next 2 months or so. That you got to be very mindful of that.
And then this one, we'll skip the other two, but this is a 47-year-old painter decorator, recent viral illness, more unsteady, feeling sick, and we're just looking at some of his clients' wallpaper, and it's not because it's offensively bad taste, it's just because there's a lot of patterns going on. And he's struggling in certain crowded spaces. His wife noticed when they were on holiday he was tripping on the cobblestones and things. Anyone want to fathom a guess at this one? I've kind of trapped you a little bit, this one. Perhaps confused you. No, there's no hearing loss, there's nothing else.
They hate going to the supermarket.
He's at Meadowhall, he's struggling going up the escalators, and when there's lots of people, yeah. So more visual vertigo. So in visually provoking environments, you'll find that there's a kind of almost a hypersensitization sort of overload, and there's this sensation that they're really going to fall over. Obviously, they're not. It's just that they're being overstimulated from an ophthalmological perspective, and they get symptoms. And that's a really good picture of what it's like. So supermarkets, crowded spaces where there's lots of people. So if you're watching a marathon or something, you might have experienced that when you're watching lots of people running on the TV. There's lots of things going on. Your eyes can't really keep up necessarily with what's happening when you're on a train, looking out the window, and there's lots of things outside. That can give you a bit of a trigger of feeling a bit like weird and a bit woozy, and that's really common and very easy to treat, again, with sort of more of your sort of general balance optimization exercises and things.
There's an increasing sort of number of people presenting with this because they're working from home. They are sat in front of computer stations. They clock off. If they're living on their own, they'll go to watching the television straight away, and they're hardly out for a whole week at a time. So the peripheral stimulations dropped in our day-to-day lives quite a lot. Next time as you're a passenger in the car, try looking at the road just in front of the bonnet, and you'll see what it feels like. Because when you're driving, you just actually shut out peripheral vision and you drive comfortably. If you start looking at stuff which are moving fast, you'll realize what it's like for them.
Again, have a sick bowl ready. We'll leave these ones. These are sort of more the ones just, again, to be aware of with your cholesteatomas, your brain abscesses and things like that, which sounds really like they're really rare as hen's teeth, but do you know what? They're surprisingly common. So if you've got anybody that's got sort of more resistant otitis externa, or that you're just not getting to the bottom of things, their hearing loss is suddenly changed, or they're getting sudden headaches, and it's just not all fitting together, don't be afraid to potentially scan their head to rule out other problems. And with your cholesteatomas especially, they can, as much as they are slow growing and they are quite insidious in how they come on, they can cause and present with more serious complications. And we've actually had quite a few in Sheffield recently that have presented as brain abscesses, so don't ignore the colon basically. And the last one is obviously the infamous acoustic neuroma. We get lots of tinnitus referrals. I'm really pleased to say that most people have already organised the MRI earlier. We did a podcast on tinnitus not so long ago, so there's some more information about tinnitus and how to manage that and what the expectations are with scanning and things. But generally we don't. Well, I don't know.
It's insidious. It's slow worsening of hearing balance symptoms with tinnitus, unilateral, and they generally compensate. So the symptoms get masqueraded quite a lot. But missing that is a problem. The yield is 1.5% on MRI scans.
So really quickly to summary, balance is really hard.
It's not hard.
It's not hard. I hope we demystified a few things. If you take one thing, it isn't. You're right. It's not that hard. It's just more that you do get that moment of like, oh gosh, when you see a dizzy person. A lot of the time, patients really want to just be heard. They may have been to lots of doctors, and in ENT, it's a surgical specialty, and yet tinnitus and hearing and balance fall under it. And there's not necessarily, there isn't very rarely an operation that we can do to help. But in the community, we have this absolute golden opportunity to be able to educate patients right from the beginning how to prevent their imbalance or their disequilibrium from ruining their life, essentially. So try and sort of keep hold of that, and as much as I know they can be a bit of an interesting demographic of patients, try not to sort of let that bias influence how you manage them and what we can do in GP before they get to ENT. Because they can be quite disillusioned when they come to us. We're going to do a balance podcast like we did with the tinnitus, and I'll get my funny headset out and make sure the sound quality is better because I'm muffled last time. And really hope that you can take some of those top tips from a perspective of extra bits of examination from today and use them as you see fit. Is that okay? Any questions? We don't have got time anyway.